tonight's session, which is all about working on an integrated care community specialist team for the older person. And before we kick off, I'm just going to run through a few quick domestics with you. So as you'll have noticed, the webinar will be recorded. If you can please kindly keep your microphones on mute. Your videos are on or off, whatever suits you best. But if you are having any issues with connectivity, please pop your video off and that should increase your bandwidth. If you're having any issues with your sound or hearing us, just check your own speaker, make sure the volume is up and it's not muted. And if that's not working for you, try logging out of the call and logging straight back in with the same link. We will be taking some questions at the end. So if you have any questions that pop into your mind, just pop them into the chat box and I'll come to them towards the end. And just to let you know, we might use some of the anonymized information from this webinar after the webinar has concluded. So the map of today is just a quick introduction that I'm going to give you now. Few minutes, then we'll have 45 minutes with our speakers, and then we'll have about 10 minutes for questions afterwards. So about an hour all in. So tonight we are in conversation with Áine O'Reilly, who is a senior pharmacist of integrated care for the older person. And we're also joined with Lorna King, who's the clinical specialist dietitian for the older person. So now I'm going to pop over to Lorna, and she is going to take us through her role as a dietitian working in integrated care and care for the older person. Thanks very much, Lorna.
Great, thank you. So I was the individual with the internet connection problems. So Grace is going to share my presentation for me because I couldn't get it to connect up. So I'm just going to move it along. So I hope it actually flows well. I want to thank Grace for getting that up for me.
No problem. 2 seconds. Here we go. Yeah. Can you see that?
Yeah, that's great. Thanks very much. And you can all hear me okay. Yeah, so my name is Lorna King and I'm the clinical specialist on the older persons team in the STEP team in South Tipperary. I'd like to thank Áine and for being invited here today to give a presentation. I suppose the fact that Áine was invited to do a presentation on integrated care and then that she asked me to do it with her, probably shows kind of how the team works in a very integrated way. So you can move. So for me, I suppose we're going to break it up into 2 sessions. The part I'm going to cover is, oh, sorry, that's actually Áine's presentation, Grace.
Oh, sorry.
I definitely won't be covering polypharmacy. And so it's the other one, yeah.
Yeah. Sorry, there we go. It should be the correct one.
Yes, there we go. Yeah, they look very similar. So that's perfect. So what I'm going to be looking at is frailty and how we have approach to managing frailty as an integrated care approach, where the comprehensive geriatric assessment fits into this, why we complete comprehensive geriatric assessments, interdisciplinary working, this kind of way of working on a team. And then I suppose to finalize it, I'll look at my experience of working with a pharmacist. So we all know that we're living in an aging population, and I suppose they're adding years to our lives. But I suppose the idea is, are we adding quality to our years, and with the increase in life expectancy comes an increasing kind of age-related disease morbidity and kind of age-related syndromes. And I suppose when we think about these, we kind of think of maybe the geriatric syndromes. And when we think of kind of geriatric medicine or geriatric syndromes, we're kind of looking at, I suppose, a term that describes a group of kind of common health conditions in the older persons that do not fall into a discrete kind of disease category. So Grace, if you can just hit the slide for me there. So really what we're looking at are things like falls, skin integrity, polypharmacy, cognition, multiple morbidity, and all of these kind of syndromes that kind of link together kind of lead to a very much kind of adverse outcome in the older person. And one of these, I suppose, again, is frailty. And while frailty is not inevitable in older persons, you are at much higher risk of developing frailty. And this does have a significant kind of negative outcome for the older person. And I suppose on the back of that, then this kind of idea of the National Integrated Care Programme for older persons was launched or developed, really kind of looking at our healthcare system and how are we going to kind of, I suppose, manage or structure the healthcare in terms of kind of managing this kind of older population and kind of living longer, which is a really positive thing, but I suppose we need to have the healthcare system to kind of support that. Yeah, so we can move on. Yeah. So from that, then I suppose there's kind of a model of care or a service model. And when we look at where our team sits, we sit there where the yellow dot is. And you can see that's kind of the older person's kind of specialty or specialist ambulatory care hub. So kind of a community specialist team for the older persons. You might know them as the ICPOP teams, as kind of the integrated care teams. But I always kind of say we can't be integrated with ourselves. We actually have to be connected up to the whole health system. So if you have somebody maybe in the hospital, they may actually be referred to us for a comprehensive geriatric assessment. And our aim will be to move them along the service towards the left so that they're living well kind of independently at home. And along that, then, they may get services from ourselves, but also we'll be linking them up with maybe their community health services within their CHN, or kind of living well at home, which will be things maybe like social care services or their home helps or their public health nurses. And that we're all integrated. And I suppose the biggest point they kind of make in the national program is that the older person, you want them to be along the model where they're meant to be. So if they're meant to be at home living independently, yes, if like people do need to come into hospital, and that they're there, but that we're all communicating with each other and that we're all kind of integrated and working together. Move on. So what's really important is kind of when you talk about working on a frailty team is like, what does actual frailty mean, or how do we like interpret frailty? And what's important there is that, sorry there now, thing has frozen. Is that we understand what the definition of frailty is, and there is no real consensus on the exact definition, but this one is quite well accepted in the literature. And I suppose it's a condition or syndrome which results from a multi-system reduction in a reserve capacity to the extent that a number of physiological systems are close to or past the threshold of symptomatic clinical failure, and as a consequence the frail person is at risk of disability even from a minor external stresses. And I suppose what it's saying there is that they kind of have a physiological kind of dysregulation. And even if they have the kind of slightest stressor, that there will be an adverse outcome. Move to the next one. And this slide kind of, represents that really well. So somebody has a vulnerability due to a reduced or adversely altered biological state. And I suppose you can have an altered biological state, maybe due to multiple comorbidities, maybe to do with polypharmacy, or kind of a number of these kind of age-related syndromes coming together. And if you look maybe at the purple line there, where somebody was independent at home, living at home, and then they have this stressor, and it can be even a minor stressor such as a urinary tract infection. And this then, maybe they're admitted to hospital, they have a fall, and then they're in hospital and there may be assistance of two, they're completely dependent, and they have gone very much off their baseline. This person is very much at risk of frailty and kind of is mildly frail. And what you want to do then is kind of put, supports in there with the multidisciplinary team to try rehab them back and get them back to being mildly frail. It was kind of originally felt that, somebody who was frail and that they had a stressor, that they wouldn't actually be able to get back to their baseline. But if you put kind of the support networks in there, people do get back to their baseline, or actually can be even better than where they kind of started out. So it is reversible. It's just about putting the right kind of supports in there. So when we think about the definition, yes, there's a vulnerability and yes, there's a stressor, but what exactly is the vulnerability and what exactly is the, what effect is the stressor going to have? So that's why you have to kind of operationalize frailty and operationalize it into models, kind of how to make it more tangible on the ground. So there's two models that are probably how frailty is operationalized. One is the frailty phenotype, which is your physical features of frailty, and the other is your the frailty index, which is kind of an accumulation of health deficits to kind of increasing your risk of frailty. So the first one we look at is the 5 physical features. And this was developed by Linda Fried in 2001. And what's really important, I suppose, is looking at the kind of complexity within the physical features. So one, you have someone who comes in, has weight loss. There's sarcopenia, so there's muscle loss. So then they go have a decrease in their strength, maybe impaired balance. They have a fall. There's kind of weakness. So the second feature is weakness. This decreases their walking speed. So you have this presentation of kind of slowness. There's a decrease in their level of activities or activities of daily living that they participate in every day. So the low physical activity level. And then there's exhaustion. You often hear this thing about fatigue. I feel so tired. And then they're back into this cycle of kind of further weight loss. loss. And really, if you have 3 or more of these, you're presenting with somebody who's living with frailty. And then it's not all about kind of the physical features. And we know that in the older person, other things will drive kind of this kind of risk of frailty. And this is kind of called the frailty index, where you have kind of an accumulation of deficits, which leads you to kind of living with frailty. So you may have cognition, where you have changes in your memory, even coming from the perspective of nutrition. If somebody isn't remembering to eat, you know, they're going to have weight loss, and then they kind of fall into the physical features where they have maybe a, you know, decrease in their weight, decrease in their muscle mass, a fall, and so on. Other things such as polypharmacy, multiple morbidities, kind of social vulnerabilities, unable to access social services, loneliness, you know, depression, and that. So they're all this kind of accumulation. And the more that you have, I suppose, the higher your risk, or the more severe you are with living with frailty. So when you think about the models, then I suppose we have to assess this. And how do we know what deficits or what physical features an individual is presenting with, and why are they frail? So if someone just said to you, oh, that person is frail, I suppose, what does it mean? What are they frail from? Are they frail from polypharmacy, or are they frail from social vulnerability, or is it a combination of all different things? So that's why we do the comprehensive geriatric assessment. So this is like a multi-dimensional interdisciplinary process, which is focused on determining an older person's medical, psychological, functional capability in order to develop a coordinated and integrated care plan. So you can see that it's not just looking at maybe at medical or physical, that it's taking in all of the features. And the CGA is not limited to just being a simple assessment. I suppose the idea is that you develop kind of a tangible intervention. So a lot of the time we get asked, I suppose, who should have a CGA? And I suppose really anybody who is at risk of, or there's concern about them living with frailty or being vulnerable to frailty, should have a comprehensive geriatric assessment done. I suppose one, to kind of, I suppose, support them in avoiding kind of an adverse outcome. And also they kind of refer to it as being the gold standard approach to kind of the management of the older person. How do you refer? I suppose we would be, every team is different in the different areas. And I suppose for the STEP team in South Tipperary, we take our referrals from the GP or the consultant, and other HAPs, say like a dietitians or a public health nurse, can recommend to the GP or the consultant that they feel that they're worried about somebody, but the referral actually does come from the lead kind of clinician. Who does the CGAs on the team? Anyone on the team can do the CGA. So I do the CGAs as the dietitian, the physio, the speech and language. But I suppose any member can complete it, so it's not specific to any discipline. And where are they done? For us, we do them mainly in outpatients, we do them in home visits, but at the triage meeting, I suppose we do it where is most suitable for the individuals. So they have been done in nursing homes, they've been done in kind of respite or rehab, or they've been done in the inpatient. Really is trying to capture where we can go in and kind of give the most support. So when you look at a comprehensive geriatric assessment, it's broken down into several domains. And when you know, I suppose, the kind of the models around frailty, it's easy to understand where the domains have come from. So obviously we look at medication, we look at memory, you know, communication and swallow, nutrition and sarcopenia, falls and bone health, social, like social assessment, living environment and engagement. And each of these domains then have an attached assessment tool that we use to kind of, I suppose, see if they're at risk of this. So say for Áine, she's developed the pharmacy prioritization toolkit. So maybe they will be, you know, positive for that. Or cognition, we use the 4AT for delirium, or the ADA to look at changes in memory or thinking over the last few years. So then I suppose from that, then you're able to kind of assess whether there is concerns around that area. And again, you're starting to see this accumulation of health deficits, and is this person going to be at risk of frailty? So the CGA, the assessment is done either by myself or another team member. And I suppose the CGA is never completed until it's been discussed at the MDM, and the MDM discussion Sorry, if we just pop back one there. Sorry, Grace.
Oh, sorry.
Oh yeah, sorry. The MDM discussion is everyone from the team, including the geriatrician. And I suppose the plan is made from there. So say if you've had a positive swallow screen, you'll be referred to the speech and language therapist. If you have had a high frax, you'll be for a DEXA, maybe bone protection. If there's been concerns around maybe your Bartel or your Lawton Brody for your instrumentals of daily living, we'd be looking at maybe the OT coming in and maybe looking at the public health nurse and doing a home care package assessment. So it's not just, I suppose the thing is that it's very holistic to the areas of concerns that have been identified. And then we do apply kind of a clinical frailty scale score. And this is one of the scaling systems to kind of identify frailty. And say if you looked at somebody there who is, say, mildly frail, these people often have more evidence slowing and help in higher order IDALs, which is their finances, transport, heavy house burden, medication, and typically mild frailty progressively impairs shopping and walking outside alone, meal preparation and housework. So I suppose the idea when you read the description and you're giving somebody a score, it's not just about physically how they are they walking with the walking frame? Oh yeah, they're mildly frail. Someone could be extremely independent and needing no support and could be quite well or managing very well. So it's not just to kind of, eyeball someone and say, oh, I think they're this score. The other thing is that the clinical frailty scale score is based on someone's baseline. It's not based on if someone has come into hospital and they're very, very unwell. So I suppose what you're always trying to say is like, what are we trying to get them back to? What's realistic to get them back to? So this is the CGA form for the STEP team. It's kind of 10 pages long, so I won't put you through all of that. So it was just to give you an idea of what that looks like. You can hit the next one, Grace. And then this is Áine's medication. So she kind of guides us through the section in the CGA. You can see there, like, find out who the pharmacist is, the blister pack, how's their adherence, where did I get my medication list from? I suppose it's all these things to prompt us to kind of collect the information correctly. And that's the nutrition one. So again, it's a malnutrition screening tool, looking at things like dairy consumption, looking at sarcopenia screening. When you go through the CGA, I suppose what you'll see is each of the disciplines or the team members have developed each of the areas, which fits in lovely with all of the domains or the kind of health deficits that are kind of linked to frailty. So a little case study then, very quickly. I suppose this was a 79-year-old lady who was referred to the team by our GP. I suppose she had a recent fall with increasing dependency on her daughter for activities of daily living. She had the CGA completed by a member of the team, and the outcome was she was for Áine. She was P2 on the toolkit for anticholinergic burden. There was an environmental kind of assessment done by the OT because of falls risk at home. She had issues with her swallow, so she was for the speech and language therapist. She was malnutrition risk and constipation. She actually had a positive ADH, so she was for a memory clinic. And then there was she had a low Bartel, 12 out of 20, and then her instrumentals of daily living. So she was for a home help assessment by the public health nurse. The dementia advisor from the Alzheimer's Society was brought in to support the lady to attend memory clinic and for her daughter. And then she had a high frac, so she was for the bone health clinic. And I suppose when I think back before I started on the team, sometimes when I'd see falls, I'd be thinking, oh, physio. But like this lady, actually, we have lots of people who go to the physio, but she didn't actually need the physio at all. It was actually lots of other kind of drivers and for her reason for a fall. So it's probably important, again, to have this kind of comprehensive geriatric assessment and to guide her in the right way. So that kind of leads on very nicely to why we work in kind of in an interdisciplinary way. I always say before my role here, I was working in adult mental health, and before that, I was working in Cork University Hospital. And I suppose when I worked there, I've described myself as working as kind of an MDT. So I worked within the dietetic department, and then I would have fed back or, I suppose given assessments in that on individuals. But I very much worked within the dietetic department, while here you're very much embedded in the interdisciplinary team. and we have a kind of an interdisciplinary way of working. So interdisciplinary teams are organized to work on a common set of complex problems. So the complex problems for us come from the CGA. So the issues that arise for the individual are driven out of that kind of common set of complex problems. And then each person contributes their skill set in order to augment and support others in the team whilst taking account of that person's contribution. So I suppose it's your responsibility as, say, Áine for us, or for myself as the dietitian, to take your skill set and actually empower others to be able to do assessments, to give out first line information, and to be able to work in this kind of interdisciplinary way, while always obviously retaining your specialist role and functions, and then communicating always actively with one another. And I suppose the way frailty presents in the older person, and the way we kind of manage it, that kind of way of interdisciplinary working is very important. So on our team, then we have the geriatrician, the registrar, the operational lead, nursing, speech and language therapy, the medical social worker, we have the physiotherapist, administration. So we're very lucky to have such a wide variety of the team. And kind of reflecting back, I suppose, Grace, if you flick on there, you can just see, when you think about, again, when I talk about the physical features of frailty, go again, and we talk about the accumulation of kind of deficits and frailty, you can kind of see really where the different disciplines fit into each of the different areas. And again, then how they've taken these kind of operationalized the frailty and actually translated it into the CGA. And that allows you then to make this kind of tangible or kind of interventions for the older person. And when I started on the team, actually, I'd come from mental health and I'd been in CUH, and I, one of the consultants was saying to me, this is geriatric medicine, we're working with frailty. And I actually was like, God, how is this going to work, or how is interdisciplinary going to work? But I remember reading a journal, and it actually said that the MDT is the engine room of geriatric medicine. And, it really is, when you think about managing the older person, it is that full MDT kind of bringing all of the pieces together to support the older person. And that's kind of what makes it work. So very much kind of thinking about, I suppose, the nutrition side. And when I came onto the team, I suppose it was kind of like, well, where does nutrition kind of fit into this picture? And I suppose looking at the models, I suppose you have the physical features around the weight loss, like the loss of muscle mass, and then you have this accumulation of health deficits. And really, I started to look at what factors really affect, nutritional factors really affect the older person. And you have reduced appetite, and there can be multiple things that can kind of affect an older person's appetite. Constipation can, different medications can, and also really thinking about things like their mood or loss of interest or depression, their kind of lack of interest in nutrition, and cognitive decline, forgetting to eat, and their memory, and then obviously there's been different kind of even medications for me, even different. We recently had a gentleman who was started on a diabetic medication which really affected his appetite, and he had like significant amount of weight loss, but also had lots of other kind of issues going on as well. So really it was nearly for Áine to have a look at more so than for me, because once that was fixed, it kind of, his appetite kind of resolved. So as a team, we're very lucky. I suppose we're always trying to see, where are the deficits in the team and how can we work together to make things, work better? What can we develop? So we looked at kind of nearly 600 CGAs that were completed in 2022. And I suppose we saw the profile of the patients that were coming out from the team, 35% with cognitive concern, swallow screen, or 31.6% had a risk of malnutrition, 68% had a fall, and we kind of looked at what was the association between, like, say, risk of malnutrition and the kind of associated drivers of frailty. And one of those that came out of it was falls, that there was an association with someone who had a risk of malnutrition and falls. And when you think back to the kind of physical features, weight loss, decrease in muscle mass, so we actually introduced kind of the screening for probable sarcopenia, which then kind of allowed for the development of a muscle health group. And there's now a joint kind of group with the dietetic and the physiotherapy. So I suppose it's just that kind of idea of examples of how we kind of work together as a team. And then kind of more working with Áine, I looked at kind of the calcium supplementation. So as we know, calcium supplementation is kind of part of the bone protection management, and it's regularly started. However, we find that maybe compliance isn't great, kind of gastrointestinal kind of complaints. Kind of a lot of time people would discuss it being affecting kind of in terms of constipation. And also, I suppose, it's not that, I suppose the intake of calcium can be quite low in the older person, so supplementation can be needed. However, I suppose the idea, actually, Grace, you can just click on two, I'd say there. Yeah. So the idea is that we kind of looked at developing kind of a calcium intake estimator. So really kind of looking at, what supplementation are you on? And then also giving kind of weight to how much dietary calcium are you actually taking in, going through that with the individual. And I suppose nearly as kind of an education as well, to say to the individual, well, this is the amount that you need. This is the amount you get from your supplements, and this is the amount that you get from your diet. And are you interested in increasing your dietary intake to possibly maybe reduce your calcium supplementation a little bit, or to kind of say why you need to be compliant? Click on, yeah. And I suppose then what we have is kind of a first line information diet sheet that has lots of sources of calcium to kind of help support people to maybe look at the calcium dietary route as well. So those the ideas that I have been kind of using it, and that Áine now is going to look at taking this on as part of her assessment as well. So she can kind of maybe guide or have a more practical, or I suppose solid reason for starting or stopping the calcium supplementation. So my experience with working with pharmacy has been really, really positive. It's been, I suppose, really educational for me. And it has, like, I suppose, in the few years that I've been there, I've definitely would say that I have learned so much from Áine. Yeah, move on. Yeah. So I suppose I kind of went through, like, when I was trying to think of the main things, and I suppose one of them is being able to, I suppose, complete the CGA and actually be able to do an assessment with the prioritization toolkit. But also really big ones for me was, one, correctly obtaining a patient's list of medications. I suppose I'd often, someone brought a list into me, or I'd seen a list in another report or something, I would have just taken that. But obviously now I know that it has to be the most current in that, or else actually finding out, is the patient actually taking the medications? And it's like things like PRN or over the counters, I probably didn't kind of see the significance as much, or have asked as much about them. So things like I wouldn't have realized around antihistamines and anticholinergic burden. Properly documenting the medication list, so using the generics. Áine, if we say a trade name, she says, "What's that? I don't know that medication." So we always have to give the generics. And also, I suppose a big one for me was when someone gives like their medical history, this is probably like very obvious to you. And when you look at the medications, that they should align, that, if someone has a condition or a disease, does it make sense to what they're on their medications list? Use of blister packs, the pros and the cons, who's suitable, that I can guide someone towards maybe starting on blister pack. It doesn't have to just always be the pharmacy, that this can be something that you can do in the CGA part. Contacting the pharmacy, like ringing the pharmacy, like it's invaluable, the information that you can get from the pharmacy. I suppose a big one for us would be like when a medication was started or when a medication was stopped, if a dose was changed, if the patient is even coming in to collect their medications. We had a gentleman who had a lot of like medications at home, and the pharmacist would say, "Oh, he came in last month, but he hadn't been in for 2 months before." So you get a real picture even around that kind of cognition part. And also I now know what a drug holiday is, so it's not that exciting. So you can move on to the next. And then I suppose the more kind of practical things was when I started on the team. I suppose even the idea that I would be kind of responsible for anything to do with medications, you will be kind of concerned. But then I suppose when I started to do the toolkit, it was really, really simple to use. I didn't actually need a lot of background information. It very much just guides you to be able to assess if there's any concern, or is somebody a priority to be sent to Áine. So you're not, I suppose, doing any of the pharmacy work. You're just able to make that assessment piece to allow the correct patients to be picked up.
Yeah.
I'll hand over to Áine now. Lorna, thank you so much for that insightful talk. That was great. I had taken notes. Watch out, Áine.
Yeah.
So we'll hand over to Áine now. And she will bring us through the role of the pharmacist within the care team.
Just click slideshow. That's working perfectly now. You're just on mute there, Áine.
Sorry about that. Great. So my name's Áine O'Reilly, and I'm a senior pharmacist working on the STEP team with Lorna, the dietitian there that just presented a lovely presentation that all things frailty. So the STEP team is a community specialist team, which is part of the integrated care program for older persons. So a lot of you might know it better as ICPOP teams, and there's lots of different ICPOP teams around the country. And as Lorna had said, that a lot of them will have different structures, different ways of working. So if there is a ICPOP team in your area, just in terms of finding out like the referral process or things like that, you could get in touch with them. Obviously for tonight, we're just talking about the STEP team in South Tipperary in terms of the way we work. So I'm going to present tonight on frailty and polypharmacy, medication review and integrated care and the use of the pharmacy prioritization toolkit, and then interdisciplinary working from a pharmacist perspective. So I suppose, polypharmacy is an international patient safety priority. I think we all know that there's no consensus definition on the definition for polypharmacy, but the most accepted numerical definition will be that of the routine use of 5 or more medications. And the cutoff of 5 is associated with the risk of adverse outcomes such as falls, frailty, disability, and mortality in older adults. But more importantly, I suppose it's thinking about the appropriateness of medications, and that forms a big part of my review. So the links between polypharmacy and frailty are quite strong. So Lorna went through in her presentation about the accumulation of health deficits and the physical features of frailty, and the impact that these can have on people. So it's not surprising that frailty is associated with hospitalization, premature nursing home admission, access in GP care and out of hours GP services, increased morbidity and mortality. But from a pharmacy perspective, frailty is also associated with prescribing of potentially inappropriate medication. So those living with frailty are twice as likely to be prescribed an inappropriate medication. And then the more medications you're on, the more likely you are to become frail. So people taking more than 10 medications are twice as likely to become frail. And then again, looking back at the diagrams that Lorna used in her presentation, so she would have spoke about this this graph with the functional ability on the y-axis and the level of dependence, and the application of a stressor, which is in the blue colored area, and you can see the loss of functional ability associated with the application of a stressor. And that's commonly, I suppose, the stressor examples can be like falls, UTIs, but again, from a pharmacy perspective, you're talking about adverse drug reactions that can have that effect on somebody so that they can reduce the functional ability. And similarly with the geriatric syndromes, so Lorna had spoke about all the different geriatric syndromes and, polypharmacy as being one of those. But I suppose, pharmacy can influence all of the other geriatric syndromes also. So you've got falls, so we do a falls review of medication and mobility, that medications can influence that. We've got dysphagia, so I would, I'm lucky enough on the team, I suppose, to have all the other disciplines even to talk through all these things. So the speech and language therapist in terms of your swallowing difficulties and medications that can affect that, like tolterodine and oxybutynin. Malnutrition, again, talking to Lorna about medications that can affect nutrition, hydration, appetite. Continence and constipation, again, medications that can affect that. And then cognition would be a big part of the assessment with our cohort of patients. So pregabalin, gabapentin, and then medications with an anticholinergic burden. So this just shows you, I suppose, the really great opportunity for pharmacists to have interventions. And literature shows that 10% of admissions in over 65 years are ADR related, and 70% of those are potentially avoidable. And that impact of adverse drug reactions, as it showed on the graph, it can be more severe in the frail older adults. And this is, again, looking at, I suppose, the influence of medication. So this is the pinch me mnemonic for the potential causes for delirium. You've got pain, infection, constipation, hydration, nutrition, medication, and environment. So medication as in and of itself, and so you've got your addition of a new medication or omission of a regular medication, but also all of the other factors again. So you've got your pain, prescribing of opioids, infection, antimicrobials, constipation, hydration, nutrition, medications that can cause that. So there's lots of areas for intervention for pharmacists. And I'll just go on to talk about the pharmacy medication review in integrated care and the use of the prioritization toolkit. So I joined the team in December 2018, and at that stage, the focus at that stage was inpatients. We were seeing 95% inpatients at that time. Then during COVID, there was a specialist geriatric ward was in the hospital in Clonmel, and that we worked on and did ward rounds daily. And then after that, and where we are currently, is where we're kind of 95% outpatients. Now we do some inpatient consults, but the majority will be outpatients. So at the time when I joined the team, the step registrar was doing the medication reviews and using stop-start criteria on anyone who was prescribed 5 or more medications. And at that time, the referral process was using this VIP screening tool. So it's a variable indicative of placement. And it was the nurses in the ED that were actually doing this screening tool by asking 3 questions. Do you live alone? Do you need help to dress? And do you need help to leave your home? And if that was positive, a referral was sent to the STEP team for a CGA, and then the registrar would do the medication review on the back of that. So when I joined the team, I just wanted to figure out a way of identifying patients with the highest risk of medication-related safety issues who would benefit most from a pharmacy medication review because of the limited resources. So in terms of developing the prioritization toolkit, then I researched prioritization toolkits that were in use in Ireland, in the UK, and other countries. There was a number of methods and criteria. Most are based on expert opinion and lacked validation, and most incorporated a list of high-risk medications and situations that would trigger a priority pharmaceutical review. So depending on the setting, there will be different situations that might trigger a review. If you're in ICU or in a respiratory ward, or there'd be different triggers. Then I looked at national guidelines in relation to high-risk medication, and in Tipperary University Hospital in Clonmel, they used the APINCH high-risk medication list, so we reviewed that. We looked at the incident reports that were reported locally, and I got feedback from members of the STEP team, other pharmacists, and a patient's perspective as well. So from the patient perspective, then talking to the patient about developing the prioritization toolkit, the patient was talking, it was a relative of a patient that was on a group that I got to talk to, and she just spoke about her experience of a relative who was admitted into ED and was on prednisolone, and it was held, but then it wasn't restarted, and it wasn't included on the discharge letter. And when they went home, and they weren't on the medication and they didn't realize that it had been stopped, and she ended up back in hospital. So she spoke about that high risk medications and ensuring that they're appropriately prescribed, and if they're held, that there's a plan put in place and they're restarted or reviewed and communicated on discharge. That there's procedures and systems in place, like annotating the Cardex with the reason for holding and documenting. Also, she advocated for regular medication review. She said, you know, medication reconciliation on admission to make sure that their medications are right when they come into hospital and also when they go home, but periodically during the stay in hospital as well. And also if the reason for admission could be associated with a medication that they were prescribed, and if they were admitted with falls, to look at medication causes. So I took all of that on board, and you know, when I first, when the prioritization toolkit was developed first, I would have had the reason for admission potentially related to a medication, but as we've moved away from the acute and into the community, I've taken that out now, because we don't really see patients in acute in terms of the reason for their admission being related to the medication. So we're kind of changing it and tailoring it as the practice changes. So I provided education to the STEP team, and in 2019 I introduced the prioritization toolkit as part of the CGA following a pilot study. And then in 2022, I introduced it into a 21-bed rehabilitation unit. So that was where nurses are identifying patients for the pharmacy review. So at that stage, I was going to a rehab unit 1 day a week. So it meant that when I went to the rehab unit, then the patients were already prioritized for a pharmacy review. So when I arrived there, there was patients already identified. And as part of that, I educated the nursing staff on the prioritization toolkit. Then in 2023, just last year, the geriatrician that worked on our team moved to CUH and has introduced it to the FIT team in CUH ED. And I, as I said, I modify it with change in practice. And the focus, I suppose, of the medication review has changed as well, in terms of the shift from inpatient to outpatient. So there's less emphasis, I suppose, on the reconciliation of medication. So because there's not that transition of care, unless there was a recent hospital admission, then I will obviously be reconciling medications a little bit more in depth. But the focus more is on the appropriateness of the medication in terms of long-term chronic management. So suggesting changes to medications in the outpatient setting when the person's not well in hospital it's more optimum, even in terms of the opportunity to discuss the changes with the patient, but also in terms of actually making the changes and following them up. So the referral process then, from a pharmacy perspective, so it comes predominantly through CGAs. So a member of the STEP team will do that CGA that Lorna spoke about, and then through the prioritization toolkit will be referred to me. And there is also referrals that come from the memory clinic. So the geriatrician that sits on our team, it also sits on the memory clinic. So if there was somebody who was assessed in the memory clinic who had a high anticholinergic burden, she might refer to me in order to reduce the anticholinergic burden, so that she can do an assessment without, with I suppose less medication with anticholinergic burden as possible. And then consultants and GPs can refer in also with the reason for polypharmacy. Now, the majority of those would have a CGA first, but sometimes if they had a CGA recently and that the only outstanding issue would be polypharmacy, then I would see them through that referral process. And we have a triage folder that Lorna mentioned as well in her presentation. So all the referrals will come in through there and are triaged, and any complex referrals will be discussed in MDT. In terms of the referral rate then, in 2022, the speech and language therapist and the registrar on the team did an analysis of the VIP referral. So that's that variable indicative of placement that I spoke about earlier, that came in through an outpatient setting. and the referral rate to pharmacy was 83% of the patients. And also I looked at the patients in the rehab unit when I introduced the prioritisation toolkit, and the referral rate was 85%. So this is the prioritisation toolkit that Lorna showed you as part of the CGA. So it's got 6 criteria. At the start, it had 4 criteria, but they were kind of, one of them actually spoke about greater than 10 medications, high-risk medications, and anticholinergic burden. So they've been separated out, I suppose, to highlight and identify them. Anybody with a specific pharmaceutical concern, so if they express a desire to reduce their pill burden, renal impairment, and falls review of medication. And the falls review of medication will be done particularly if a patient has falls, but the majority of patients, older patients, need a falls review of their medication in a preventative way, even if they haven't fallen. This is a list of the high-risk medications that are included in the prioritisation toolkit. So as you can see, they're not exhaustive, and they are chosen based on the commonly prescribed medications in our area. So if you were to move to a different area in the country, the prescribing practices might differ. So you might have different medications on your prioritisation toolkit. You've got long-term antimicrobials. I've increased falls risk increase in drugs that are not included on any other lists. So your doxazosin and tamsulosin, and it's lovely to see, even as part of the CGA, I'd noticed that sometimes whoever, it could be Lorna or the physio or the OT who's presenting the CGA, and they might have recorded the line and stand and blood pressure and say that they've got orthostatic hypertension, and now from working together, they're able to identify medications that could be possible contributors. So it's a really good education tool, as well as a tool for me as a prioritisation toolkit. And then medications with anticholinergic burden. So as I mentioned earlier about the referrals that sometimes will come from the memory clinic about weaning medications with anticholinergic burden. And there is a ACB calc that you can use in terms of the scoring for the anticholinergic burden medication, and the score is cumulative. So this is it outlines the content of the reports. So this report, it details your history, the medications, allergies, the anticholinergic burden medication, a falls review of the medication, but also looking at the FRAX when they last had a DEXA, and history in terms of the bone protection, and to see, as Lorna mentioned earlier, about the drug holidays and the bisphosphonates, and just trying to figure out how long they've been on them, and do they need to go through the bone health pathway in terms of to be reviewed post DEXA. QTC prolongation, so to look at medications that can prolong the QT, and also bloods and interactions. And this was a template that used to be sent to the GPs, but feedback recently from the GPs was that they wanted a much more condensed report. So whilst I still do all this assessment, they only make it onto the report now if there's a recommendation that actually comes from it. And I tend to use the 7 steps approach in terms of the framework, in terms of medication review, and the stop-start criteria, stop frail where appropriate, and just constantly reviewing the benefit and the risk, and discussing that with patients in terms of how they perceive the benefit of the medication. And all of these are discussed at MDT with the STEP team. So on from the medication review then, I also do a deprescribing clinic. So recommendations to wean medications, I'm able to follow them up. So that's a once weekly clinic. It's mainly done virtually, in person if the patient wants to, and sometimes through a family member if they prefer that way, and that the family member would feedback from the patient and I'd ring them. And then I'd liaise with the GP if the dose change wasn't tolerated. So this support mechanism for the patient, I think it influences really the outcomes in terms of them accepting a recommendation to wean a medication, because I think they find that availability of support and knowing that somebody's going to ring them in a couple of weeks to find out how the change in the medication, they feel much safer and happier about the change happening, and knowing that that support is there. So interdisciplinary working then from a pharmacist perspective. So you've got your, Lorna spoke about this, contributes their skill set in order to augment and support others and retain specialist roles and functions whilst communicating actively with one another. So we've got comprehensive medication review, so recommendations, it's I suppose around optimizing medication. So as Lorna said before about looking at the history and the medication list, and making sure that there's a reason, like, I would have come across one, I suppose, extreme case in the sense that there was a history, I was looking at a medication, somebody was on an antipsychotic, and looking at the history, there was no history of mental illness. And I rang the GP just to follow up, and it transpired that the patient and his son had the same name, and 2 years ago the son's medication was changed and it was transcribed onto the father's medication record in error. So he'd been on an antipsychotic medication for 2 years, and I suppose it was hard to pick up because the prescription, the dose was correct. There wasn't actually any interactions, anything wrong. It was just to pick up that he didn't have a history of it, and that's very difficult to pick it up. If you get a prescription into a community pharmacy, you don't have access to the history of the patient a lot of the time. And I suppose that's what's really good even about the medication reviews on our team, that I send the reports both to the GP and the community pharmacy. So I'd like to think that it would give the community pharmacy an overall picture of what's happening with the patient, and then picking up on deficits that mightn't be evident at the time of CGA. So that's more around, I suppose, if a referral was suggested, say, to the likes of Alone, and they refused it at the time, if for whatever reason that they weren't ready to accept it. Sometimes when there's a time lapse in between the CGA and the medication review, and they might be ready to engage by the time I've come, because they've had time to process it and think about it. If they've been referred to the memory clinic at the time of CGA and something has changed in the time frame between the CGA and the pharmacy review, sometimes I'm able to prioritize the medication or the memory clinic referral, obviously after discussing it in MDT with the geriatrician. And if they had an episode of delirium, which can sometimes happen in between the CGA and medication review, we could refer to the delirium clinic. And oftentimes I'd contact the public health nurse as well about concerns about, say, the home help service provision. And then contributing to the MDT. So I suppose that's kind of through constant communication and education in the MDT setting. So I think that's why it's really valuable to sit on the team rather than to have access to pharmacy, so that they'd have to like an integrated care team might ring to have a medication review completed by a pharmacist, but whereas when you're sitting on the team, you're able to educate and talk about that brand prescribing and discrepancies with frequencies and the renal function. So like the difference between your creatinine clearance and your EGFR, and abbreviations with microgram, duration of bone protection, and it just allows pharmacists to influence decision making at that point. Then awareness of pitfalls and common errors, so inaccuracies in GP lists that would happen quite a bit in terms of historic medications being included on GP lists, and that's why we find it so invaluable being able to ring community pharmacies and get that accurate list of medication. And it's great, it's just such a great resource to have, and to have accurate list of medications. And then I do feel like a valued member of the team, contributing to positive health outcomes for patients. In terms of service development then, so when I would have started on the team, I would have always, I suppose, reported a FRAX on not all the patients, but patients who, which is your fracture risk assessment, on patients who I thought would need a fracture risk assessment. And the geriatrician at the time, when I was reporting on the FRAX, she thought it was a great idea, and that why couldn't other members of the team do that? And now it's embedded in the CGA as part of, so it's done on every patient that has a CGA. Similarly, highlighting medications that cause postural hypotension as part of the falls review. You know, it highlights even more in terms of falls that, you know, that these could be contributing. And now we they record lying and standing blood pressure as part of the CGA. And Lorna talked about where they do CGAs, so they do them in the home, I'd say for the last maybe 2 years. But recently we've introduced home medication reviews as well. So, and again, that wouldn't probably have happened if you're not on the team, you know, like identifying patients who might benefit from a home medication review. And I did a joint visit actually with Lorna there not so long ago. And then delivering education to patients. So myself and Lorna actually deliver education to Parkinson's support group as well. So then from the value of the multidisciplinary team for medication review, so there's the contributions from other members of the team. So from the other side of things, other members of the team positively influence my medication review in terms of the information that they provide during the CGA. So they look at concordance, barriers, resources. They refer to the memory technology library for help with medication compliance. They look at the clinical frailty score, which obviously helps me as well in terms of the decision making around recommendations for medications. And they've done the CGA and assessed the patient in person, so they'll have invaluable insight into aspects of the patient and how they manage their medications, especially if they've done the CGA at home. They can see exactly where they store their medications, how they manage them on a daily basis. And then the geriatrician, so the support from the geriatrician on the team is invaluable as well. So, you know, the geriatrician or the registrar will order DEXA scans if they've elevated FRAX, refer to medical clinics if it's required, and just support in that decision making and guidance with medication recommendations. So, like if I thought, I wonder if we could reduce the diuretic, the geriatrician is able to review the echo and look at other clinical aspects, so that there's more informed recommendations being made. And then providing the information, leaflets, advice, and signposting. So Lorna's developed a folder on the step drive that has lots of leaflets and information that we can hand out, and we I commonly hand them out to patients around nutrition, constipation, bone health, delirium, counselling services. And then there's signposting to counselling services, alone, grant application, OT, contacting the public health nurse, as I said before. And then just as a last note, I suppose to mention Niamh McMahon, who is the Chief 2 Pharmacist in St. James's in Trinity College Dublin. So she's the pharmacist representative on the National Integrated Care Programme for older persons. She's also the pharmacist representative on the HSCP group within the National Integrated Care Programme for older persons. She's been involved with, amongst other pharmacists, in the development of the knowledge and skills framework for healthcare professionals working with older persons. So there is, a pharmacist voice in that document, and that's due for formal launch on the 30th of May this year. And she's just strongly advocating and fighting for pharmacists' inclusion in integrated care teams nationally. So hopefully that will happen. And then just lastly to mention the National Frailty Education Programme that is delivered nationally. So there's a polypharmacy module within the National Frailty Education Programme. And, it's really good as pharmacists, I suppose, if you were interested in providing that education, if it is being provided locally to you to see if it might be something that you would be interested in doing, or becoming a facilitator as part of the National Frailty Education Programme. And that is it.
Thank you so much, Áine. That was very informative, and to Lorna, that was great. I've learned a lot tonight. We have a question here from Paula. She's just wondering, how long does the average medication review take you?
So I'd say probably, like, I allocate 2 hours. So sometimes it can take like an hour and a half, and sometimes it can take, like, I could actually be on the phone to a patient for over an hour, like without even looking at the notes and ringing the pharmacy. And so it is quite time consuming, because it is that element of, it's looking to see that they're on that antipsychotic and you can't see a reason why, and you're ringing to try and find out when, and they're on a bisphosphonate, and when was this started, and you know, they were on a drug holiday 3 years ago, or then you look and you see it was missed off in hospital and why. So there's a lot involved in it, so it is time consuming. And then you have the report right up after the MDT, which would take another 20 minutes or whatever after the MDT to kind of close out the report and send it out after.
Brilliant. Thank you so much. That is the only question in the chat, and in the interest of time, I'll move on. That's all right. But my thanks to both Áine and Lorna tonight. We will be popping out a survey, and it's going into the chat box there. If you could take the extra 2 minutes just to quickly click on the link in the chat, and we'd really appreciate a little bit of feedback, because obviously sessions like tonight are based on the needs of the community of practice. So the more you tell us about what you need, the more we can align in conversation with sessions to what your needs are. So thank you for that. So while you have your screen still in front of you, it would be great just to jump into your portfolio, start to cycle quickly, get some bones onto it. You can always finish it later, but as we all know, we'll say we'll do it tomorrow, and then sure, tomorrow comes and goes. You're like me, you're still saying you'll do it. Now, we will have our next in conversation session on the 24th of April, and this is another multidisciplinary team, and it's looking at diabetes. So we have Dr. Kathy Breen, who's a clinical specialist dietitian. We'll have Yvonne Maloney, who's a registered advanced nurse practitioner, Lisa Devine, who is a GP, and they're all from the National Clinical Programme for Diabetes. So we'll be looking again at diabetes through the lens of the multidisciplinary team. So thank you all for dialing in. We appreciate you hanging on at the beginning. We were a few minutes late, but for now, thank you and good night.